Good morning. Today we are going to discuss an important case which visited my OPD. A mother came to my OPD with her 6-year-old daughter with a complaint that she is not able to close her left eye, and she has some difficulty in drinking liquids also, that the water comes out from the angle of the mouth. When I examined her, we can see in the video that she is not able to close her left eye fully, but there is also difficulty in complete closure of the right eye also. And when she was asked to purse her lips, she was not able to purse her lips fully, and she had difficulty in whistling also. And when she was asked to look at the ceiling to make the wrinkles on the forehead, when she saw at the ceiling there were no wrinkles. So there was clearly involvement of the bilateral side of the face, that is bilateral 7th cranial nerve was involved, which appears to be LMN. Then I also examined the mother also. She doesn't have any complaint, but we can see in the video that she also has a similar complaint. There is involvement of the bilateral 7th. So this was a case of bilateral 7th intranuclear palsy, which appears to have some familial predisposition. So today we will try to approach how to approach such a case. In bifacial weakness, when we divide the causes, it can be divided in UMN causes and the LMN causes. We know that bilateral 7th cranial nerves, they start from the pons. So any bilateral, any pontine lesion can explain it with any brainstem lesion, with if there was involvement of the in addition to it, if there is involvement of the abducent nerve, then a syndrome is there which is called Mobius syndrome. So in the LMN causes, we can divide as the anterior horn cell disease, anterior horn cell, then nerve lesion, neuromuscular junction, and the muscle. Anterior horn cell disease, they usually do not involve the 7th nerve, except facial onde. There is involvement of there is difficulty in swallowing also. So facial onde and BVL, that is brown Walrat syndrome, they both can cause bilateral 7th. The most common causes in OPD which will come with bilateral 7th, they have the neurogenic causes like GBS, then sarcoid, then Lyme's disease, and other causes. Though Bell's is unilateral, but sometimes the causes can be idiopathic, that is Bell's palsy and tic paralysis. In neuromuscular junction causes, we have the myasthenia gravis and botulism. And now we have another muscle disease which can cause bilateral 7th, that is bilateral facial muscle weakness, that the lesion is with the facial muscles, not with the nerve. So the muscle causes are, one is the myotonic dystrophies, congenital myotonic dystrophy. The patient have a typical facial presentation in which there will be the face is like a fish mouth, inverted V sign is there. Then patients with FSHD can also have bilateral 7th involvement. And in congenital myopathies, they can, centronuclear myopathy, they can have bilateral 7th. So we have to approach the bilateral facial weakness in this way. Thank you.